So it's my presentation today is about management of Azospermia from the national perspectives. Next. Regarding disclosure, I have nothing to disclose. Thank you. Next. So Azospermia is defined as absence of sperm cells in the ejaculate, and it's found in 15% of infertile men and can be classified as obstructive or non-obstructive. In North Africa and Middle East, we don't have kind of a strong epidemiological studies. Next. One of the interesting studies by El Bardisi and colleagues, I think Dr. Arafa is one of the co-authors in this article. The study included more than around approximately 14,000 infertile men, and reported that the frequency of Azospermia is lower in our region compared to the rest of the world. When age was factored in, the prevalence of Azospermia in men above 40 was significantly higher. The only observations with this study is that the cause of Azospermia has not been declared. And the second observation that the majority of people living in Qatar, where the study was conducted in, were actually foreigners working on work permit or a permanent resident in Qatar. So the demographics was not clearly stated, but however, the study is very good because it included a significant number of infertile men. Next. So obstructive Azospermia comprises about 40% of Azospermia, and it's typically accompanied by a normal testicular function. So whenever we take a testicular biopsy from those patients, we find a normal spermatogenesis. The obstruction could be any way from the retitestis to the ejaculatory duct. Next. Absent vase is one of the commonest causes of obstructive Azospermia. It could be unilateral obstruction or bilateral absent vase. So, so CFTR gene mutation is common, and ultrasound examination on the abdomen is really required in patients with unilateral absent vase and negative CFTR gene mutation. Next. So LCD and co-workers in Egypt conducted an interesting study about CFTR gene mutations in 2016, and they found 13 mutations. 4 of them were really novel. The authors confirmed that mutations and polymorphisms were not previously described in the Egyptian populations. Next. In another Egyptian study by Shaheen and colleagues, the authors noted that the genotype-phenotype correlation is not always easy to establish. DNA sequencing is required to detect further mutations that will provide the basis of neonatal screening as well as prenatal genetic diagnosis. Next. Congenital bilateral absent vase difference incidence in Egypt is so far unknown. We don't perform in our country routine check for the newborns to screen for cystic fibrosis. Therefore, the incidence data of CFTR related cystic fibrosis is not available. Next. However, the incidence in some countries like United Arab Emirates is 1 out of approximately 16,000. In Bahrain, it's 1 out of 6,000. The reported prevalence is significantly lower than in European nations, ranging from 1 to 2,000 to 1 to 4,000, as well as United States. It's around 1 to 3,500. The prevalence of consensual marriage in Qatar is 44%. That's comparable to our reported consensual marriage that ranges from 29 to 50%. Next. It's predicted that our national incidence of CFTR mutations is even lower than what is reported in the United States and in Europe. Therefore, the decision to screen the partners for CFTR should be case dependent, and it should be patient centered as well. The priority is given to men with congenital bilateral absent vase. So, especially if the man is married to his relative. Next. So ICSI offer a good chance for those patients to conceive. Partners who both carry the mutations should be advised to have PGD. In this case, it's PGDM or monogenic disorder to avoid passing the abnormality to their offspring. Next. Oh, this table shows the methods to retrieve sperms from obstructive azoospermia, and I think Dr. Silber has clearly elaborated this kind of slide. So, but just briefly, MESA require microsurgical skills. This is the main disadvantage, but offers a large quantities of sperm that could be used for IVF and ICSI. On the other hand, PISA offer like it doesn't require a microsurgical skills. It's less costly. And does not require even like doesn't have a post-operative pain associated with other kinds of microsurgical sperm retrieval. TISA or testicular sperm aspiration is also favorable. It's an outpatient procedure, fast and easy, minimum post-operative discomfort, and it's also considered minimally invasive if we compare it to the regular testicular sperm extraction. Next. Non-obstructive azoospermia is very important in this topic because primary testicular failure is a leading cause of non-obstructive azoospermia. Impairment of hypothalamus and pituitary comes next, and Dr. Aimer will talk about that. The development and widespread adoption of ICSI in Egypt have enabled men with primary testicular failure to have their own genetic children. Next. Genetic testing is conducted to evaluate the transmission of health-relevant genetic lesions that are critical to consider when counseling and treating affected couples. Karyotyping is one of the most common cytogenetic anomaly, especially the non-mosaic type. In an Egyptian series that including more than 200 patients, non-mosaic Klinefelter were about 92% of the cases. Next. So Turner syndrome was the most common one, especially for patients visiting the endocrinology clinic rather than infertility clinic. The diagnosis also of Klinefelter offers some challenges because those patients are at a higher risk of androgen deficiency, osteoporosis, metabolic syndrome, type 2 diabetes, breast cancer, and germ cell tumors. Other cytogenetic abnormalities detected in azoospermia, including translocations. So these translocations are balanced, but whenever we do ICSI, these balanced translocation may result in embryo aneuploidy and may result in ICSI failure. Next. Recently, Shafi et al., it's also a paper published in Egypt, reported that Y chromosome microdeletion is found in 16% of men in the study population. However, Y chromosome microdeletion testing is not widely adopted at the national level, partly because it's expensive. It costs around 3,000 Egyptian pounds, approximately $200 US. That's a significant amount of money, and to a lesser extent to technical constraints. Next. Given the fact that testicular sperm retrieval in men with ASF-A and B deletions is rare, and sperm donation is prohibited in our country. So in our country, in Egypt, so sperm donor and oocyte egg donation is absolutely prohibited. Actually, a third party is absolutely prohibited by law. So we recommend TC attempt without the support of Y donation. Not recommend, but this could happen because again, sperm donor is not an option. So we will go for TC anyway. However, genetic counseling is always required. So male ICSI babies of men with non-obstructive azoospermia are most likely to have the issue of azoospermia for the male offsprings. Also, those patients are at a higher risk for male Turner syndrome or even sex reversal syndrome. So that must be considered when we counsel the patient prior to ICSI. Next. This is regarding hormonal treatment or hormonal optimization, as we said. So aromatase enzyme inhibitor is one of the options. Treatment before TC with HCG, HMG, or using clomiphene citrate. The main idea here is to increase the intratesticular testosterone production. So basically, testosterone levels inside the testicles is 100 times than the serum levels. And these testosterone levels are important to restore Sertoli cell function, to improve DNA synthesis in the spermatogonia, to enhance spermatogenesis and spermiogenesis, and improve spermiation. So again, hormonal treatment is debatable, as we will discuss later. Next. In a larger non-randomized study that's conducted in Upper Egypt, involving more than 600 Egyptian men, the hormonal optimized group have a higher chance of sperm retrieval, 57% compared to 34% in the second group. The evidence is insufficient, however, to recommend hormonal optimization prior to TC, and we agree with Dr. Server, as we said, we don't offer this as a routine. Next. Again, Dr. Arfa covered this topic very well. Varicocele is observed in 4 to 13% of men with testicular failure. The exact link between varicocele and non-obstructive Azuspermia is poorly understood. Spermatogenic failure has been reserved as early as 1955, as Dr. Arfa said. Next. Steve and colleagues in their systematic review reported that varicocele ligation or embolization in men with non-obstructive Azuspermia revealed that spermatozoa appear in the ejaculate in 44% of treated men. Men with documented hypospermatogenesis are more likely to respond if we compare them to the patient with Sertoli cell only syndrome or complete maturation arrest. Next. Given the prognostic potential of testicular pathology or biopsy at the time of varicocele repair may provide useful information. However, it's too late because usually the biopsy is conducted during varicocele repair, so there is no time to counsel the patient, but it offers a good prognostic value. Independent factors such as varicocele grade, testicular volume, preoperative FSH are not reliable predictor of fertility outcomes. However, I do agree with Dr. Arafa that clinical varicocele is the way to go. Next. Azuspermia relapse also is not uncommon. So 7.7% of men with hypospermatogenesis may relapse to Azuspermia, and almost 70% of men with maturation arrest may relapse to Azuspermia. Next. The pregnancy rate ranged from as low as 4% to as high as 19%. Varicocele repair may improve sperm recovery in men with non-obstructive Azuspermia, and I guess this is the second target. A recent systematic review suggests that the likelihood of a sperm recovery is 2.6-fold higher in men with varicocele associated non-obstructive Azuspermia if the varicocele is treated before attempting sperm recovery. Next. Testicular histology is so far remained the main predictive factor for sperm recovery. As Dr. Serber said, the wide adoption of transcriptome analysis may be a good promising alternative, but again, because of the technicality, it's a limited choice in Egypt due to the cost and technical constraints. Although the evidence supports consideration of varicocele repair in men with non-obstructive Azuspermia, the discussion with the patient should be the main goal. So again, as Dr. Arafa said, we don't recommend varicocele repair in men with wife that's above 39 or above 40 years old. So it doesn't make sense. So it should be case dependent. Next. This slide briefly describes the MicroTC. That's okay. Again, we need a microsurgical skill, a good surgical microscope, and under optical magnification, we select the widely dilated seminiferous tubules, and we published a paper on fertility sterility like 10 years ago, and we had a cut-off level of 300 microns. So this is a good cut-off level where we can retrieve a testicular sperm. The harvested tissues are mindset mechanically, and we look for sperm cells under the inverted microscope, and then we do sperm processing. We treat the tissues with erythrocytizing buffer or enzymatic digestion, and the sperm cells either injected, ICSI in the same day, or frozen for later use after ovarian stimulation. Next. This table briefly describes the differences between using fresh versus frozen testicular sperm from the time perspective. Logistics, it's easy to use a frozen testicular sperm because, again, it's challenging to coordinate the OR. Again, sperm survival, from the sperm survival perspective, cryo damage may happen with the frozen testicular sperm. Pointless ovarian stimulation may happen if we prepare the wife and do TCX in the same cycle. This is rare with a frozen testicular sperm. Again, we can offer freezing of oocytes. That's really interesting and a very good option, especially if the wife is below the age of 37. Very low number of sperm cells could be retrieved. That's why if we are using fresh testicular sperm, we inject what is available, and we can, of course, freeze the remaining oocytes, or use a single sperm freezing if we are using a diagnostic and using a frozen testicular sperm. Regarding ICSI outcome, the frozen testicular sperm have a favorable outcome, and we don't have issues using them in ICSI. Next. Important consideration include here the patient-centered approach and patient counsel, including the age of the wife. Involvement of genetic consultant is important as well. Economic evaluations of the intervention, cost effectiveness, cost utility analysis if the funding model is public, and cost benefit analysis if the funding model is private. And again, I have the honor to present to you to this lecture. I'm willing to hear your questions. Thank you so much.
Thank you, Dr. Wael, for the nice presentation. Can I please ask the management to get the questions for the audience? And after this, Dr. Wael.
While having the question for the audience, yes, I have a question for Dr. Silber from his friend and my friend, Boutros Rizk. Do you hear me, Dr. Silber?
You know, I just had to turn off for a minute because I had a question from the hospital. So could you repeat the question? I don't know.
Yes, Dr. Boutros Rizk asking you a very important question. How long will it take you to make fibroblasts sperm into sperm?
Well, I'm predicting I'm fairly confident we'll be able to have this in 10 years. And here's what, maybe a lot sooner than that. We're making the PGCs, so that's important, but we need the fetal somatic gonadal cells. Now, for the eggs, what we're working on now is growth factors to convert stem cells in a different culture dish to fetal granulosa cells. So that'll come first, but maybe not, because the testis is a more complicated structure really than the ovary. I don't want to offend the women in the audience, but the testis is a much more complicated thing. But since the human pubertal testis, the early pubertal testis, is really just like the mouse neonatal testis, it's possible that we can take these PGCs if the person is young enough, like a cancer patient. It's possible we can take the PGCs and inject them into the radi testes, and it'll be no different than in the animal model, injecting into the fetal or neonatal testes of a mouse or a rat. So I'm sure that we'll be able to make sperm for the young boys who had cancer that didn't have their testes frozen in 5 or 10 years. But to actually, in a test tube for an adult may be tricky. We'll have PGCs. I don't see that as a problem, having PGCs in these men. But getting a fetal or an early pubertal testicular structure, like an organoid, to mature those PGCs in, I don't know, that might take longer. But so I'd say 10 to 15 years, but I'm just guessing on that. But I think much sooner, maybe even in 5 years, we'll be able to, for the prepubertal or pubertal boy, we'll be able to do a skin biopsy, inject PGCs into the radiotestes.
Thank you, Dr. Silver. Dr. Wael, would you comment about the answers?
Yeah, sure. So the first question, which of the following is true in congenital absent vase? So basically, the 52% of the audience stated that ultrasound on kidney is recommended for men with unilateral absent vase and positive CFTR mutation. So basically, yeah, this is true, but only when the CFTR mutation is negative. The correct answer is the frequency of CFTR mutations varies among different populations. And as we stated that in the United States, it's 1 out of 3,500. In United Arab Emirates, it's 1 out of 16,000. The second question, which of the following techniques is not suitable for sperm retrieval in obstructive azoospermia? So the correct answer is electroejaculation. That's right. 78% got it right. Which of the following is true regarding genetic testing of non-obstructive azoospermia? The genetic testing is not required, 33. The majority said like 39%. The second most common is the Klinefelter syndrome. But actually the correct answer is identification of translocation predict embryo aneuploidy. So balanced translocations, even because it's balanced and the infertile man is absolutely right. Those patients, when they go ICSI, the embryos will have a higher rate of aneuploidy and structural anomalies in their cytogenetic profile. Varicocele repair in men with non-obstructive azoospermia is associated with relapse to azoospermia. That's right, 57% got it right. ICSI with frozen testicular sperm is associated with the following issues. Cryo damage. Yes, cryo damage is one of the causes of one of the issues that we face with sperm freezing. It's not that common, but it could happen. And 33.3% got it right. Thank you so much.